Good morning, everybody. We are starting a new session, and today we're going to study the diseases associated to the pituitary gland. For the purpose of this lecture, we will only study some of the pituitary main diseases and the ones that are produced by pituitary tumors. We don't have time to go into most of the congenital abnormalities of hypopituitarism. This will be covered in each particular uh, hypothalamic pituitary axis lecture that you will start next week, such as the hypothalamus pituitary thyroid axis, hypothalamic pituitary adrenal axis, and the hypothalamic pituitary gonadal axis, and also in the sessions and lectures that you will be studying about type 1 diabetes and type 2 diabetes. If anything is not fully answered in one lecture, you will see that because these lectures are physiology and physiology links one lecture to the other one, just like the endocrine organs. The endocrine organs need to talk to each other to express certain hormones to tell the other organ to express another hormone that has a physiological function. So at the end of this module, you will have a very deep understanding of all the physiological roles of each specific axis. So what are the learning outcomes from the lecture today? By the end of this session, you should be able to understand the pathophysiology of hormone imbalances. Not all, just few. Discuss and explain the etiology, presentations, and diagnosis and treatments of major disease of the pituitary gland, such as pituitary adenomas. As we will study, these are pituitary tumors, hyperprolactinemia or oversecretion of prolactin, prolactinomas, which are pituitary adenomas that oversecrete prolactin, and acromegaly or gigantism, which is oversecretion of growth hormone due to pituitary tumors that secrete too much growth hormone. I just very summary lecture outline. The disease of the pituitary, anterior pituitary. So mainly there are pituitary tumors called pituitary adenomas. We will look into treatment of these pituitary adenomas. We will study hyperprolactinemia and prolactinomas, the etiology, presentations, investigations, and management of these two conditions. And then we will look into acromegaly, epidemiology, etiology, presentations, investigations, and management. We're also going to study some hormone imbalance that we studied yesterday in the last lecture. If you remember, we studied the arginine vasopressin or antidiuretic hormone. So what happens in the syndrome where there is abnormal secretion of antidiuretic hormone, and also when there is too little of antidiuretic hormone, such as diabetes insipidus. We will study all this slowly in this lecture, and obviously we will have a break in between. This is only a small portion of what we know about pituitary disease, because here there are lacking craniopharyngiomas, congenital hypopituitarism, and lots of other conditions, such as, for example, viper bites, snake bites that produce hypopituitarism, or for example, mechanical or autoimmune disease. But we will need another 2 lectures to cover all the diseases of the pituitary. So this is just a thorough but a good overview of the main pituitary disease. So let's start with this chap. Obviously, I cannot see you, right? And I cannot ask you things. But if I was in the class, I will ask you, what condition does this gentleman has? And what do you think? Does it remind you someone? As you can see, has very big jaw, very big ears, very big nose, so has cranial progmatism, mandibular progmatism, and you don't see here, but it's got very, very big hands. These are clinical features of acromegaly. This acromegaly occurs in patients that has oversecretion of growth hormone. And this person become very famous. The reason is because from this person there was the character of the draw of Shrek. Can you see? The big hands, big mandible, big nose. And it actually is a real person that lived from 1910 to 1955. And his name is Maurice Tillet. And he had acromegaly. First thing to notice from the clinical point of view is that this chap died at the age of 45 years old. So one of the consequences of having acromegaly, as we will study later on, having acromegaly with a pituitary tumor that oversecretes growth hormone is not only there is abnormal growth of the mandible, the ears, the eye, and the hands, but there is also associated comorbidities with abnormalities in the heart, in the bones, with severe osteoporosis, and also hypogonadotrophic hypogonadism or infertility. So the life expectancy of these patients is very low compared to the normal population. And we will study this. Again, due to a pituitary tumor, the pituitary tumor sometimes is not only the over secretion of some hormones, but the problem is that this tumor grows into the hypothalamus. And the hypothalamus, through the leptin system, controls satiety and feeding behavior. You can see here a child with a pituitary tumor, and after operation, she gained 150 pounds within 2 years after removal of the benign tumors in the hypothalamus. So you can see that hypothalamic obesity due to a pituitary tumor is very prevalent and can be severe and affect the morbidity. This is one of the craniopharyngiomas of our patients. Is another type of tumor. We will not study it in this session because we don't have enough time, but you can see the big tumoral mass on the MRI here growing in the hypothalamus pituitary area. Remember, this is a sagittal section on the MRI. We can see the brain, you can see the corpus callosum, we can see the third ventricle, the hypothalamus in this area, and the pituitary just there as a bright spot. However, in here in the patient has a big tumor mass. So normally the tumors are presented with raised intracranial pressure due to growth, obviously, of the tumor within the brain, headaches, suppressed endocrine dysfunction and visual disturbance, and obesity. So the diseases of the pituitary gland, anterior pituitary gland, because obviously there is the anterior pituitary gland and there is the posterior pituitary gland. So things are not as easy as they may seem. So this is a general draw explaining all the anterior pituitary disorders that you must know. So 30% of all the pituitary tumors are non-functioning pituitary tumors. What do we mean by non-functioning pituitary tumors? Is that they do not secrete hormones. The other percentage is functioning pituitary tumors. That means that the tumor itself overexpresses one particular hormone and there is increase of this hormone. So from the non-functioning pituitary tumors, basically the tumor is presented by pressure on cells. The tumor itself makes stop the cells from functioning. There is obviously a decrease on hormones leading to hormone deficiency. If you think about the tumor grow with too much, it can stop the interaction with the hypothalamus. And what we studied in the first lecture is that the hypothalamus regulates the pituitary. Therefore, it can lead to deficiency in hormones and also hypopituitarism. Also, there are lots of effects on symptoms due to the space of occupation. If the tumor grows too big into the cranium, may affect the optic tracts and the brain. So very important mass effect. How about functioning pituitary tumors? They produce hormone hypersecretion, syndromes of hormone excess, because if the tumor expresses too much ACTH, or for example it expresses too much growth hormone, or too much thyroid stimulated hormone, or too much of adenocorticotrophin, that will have an impact on the whole body homeostasis. Also, it has an effect on the space occupation because it grows next to the brain. So in terms of the non-functioning pituitary tumors, they can lead to several or one hormone deficiency, such as, for example, ACTH deficiency, TSH deficiency, leading to secondary hypothyroidism, growth hormone deficiency, LH and FSH deficiency, or non-functioning pituitary adenomas, then affecting fertility and development of the gonads. Also, too much if the connection between the hypothalamus and the pituitary is broken because of the tumor, remember the prolactin needs to be inhibited by which molecule of the brain? By dopamine. Remember, guys? Prolactin is in constant inhibition of dopamine. So if there is breakage with the hypothalamus because there is a tumor growing, then there's going to be more secretion of prolactin, leading to hyperprolactinemia. And obviously, if the tumor affects lots of cell types, it can lead to panhypopituitarism. So how about functioning pituitary tumors? They can express too much prolactin, and they are called prolactinomas. They can express too much ACTH or adenocorticotrophin hormone, and this leads to Cushing's disease. And we will study this next week when we study the hypothalamic pituitary adrenal axis. This is covered in lecture 21 to 24 in the adrenal cortex disorders. It can lead to overexpression of TSH or thyroid stimulating hormone. Then obviously this leads to tumors known as thyrotropinomas. They are very rare, but obviously it will affect the metabolism and the thyroid gland. There are other tumors affecting the growth hormone, and this can lead to either acromegaly, but if the tumor is present before the age of pubertal growth, can lead to gigantism. We will study this in the second part of our lecture. And then there can be tumors with oversecretion of LH and FSH. And these are really very rare. Normally, the symptoms are due to a space occupation or known as mass effect, and the normal presentations are headache with visual field effects because obviously it's growing in the visual tract and it compresses the visual tract. And obviously there's cranial nerve pulses because it can affect also the cranial nerves. The anterior pituitary adenomas, we're going to start. Let me just check, guys, that this is being recorded. 1 second. Sometimes. Yeah, I think it has been recorded. So, how about the pituitary tumors? How are they classified? Very important for the medical students, right? So the anterior pituitary tumors are called pituitary adenomas. They do not metastasize. That's why they are called adenomas. And they are classified into microadenoma and macroadenoma. And they are classified depending on the size of the tumor. Microadenoma is smaller than 10 millimeters, whereas macroadenoma are tumors which are bigger than 10 millimeters. Remember that the pituitary is very small, so 10 millimeters is a lot, right? So they are classified as non-function microadenomas, which are normally smaller than 6 millimeters and are presented up to 10% of the total population, my friends. 10% of the total population means that if there are 200 students in your class, right, 20 students will have a microadenoma in their life. Okay? But don't worry, because most of them are non-functioning and do not produce symptoms, as we will study. But they are very, very, very common. What happens is that these micro non-functioning adenomas are too small to cause hypopituitarism or hormone imbalances. So we can assure the patients that no intervention is needed, although perhaps there needs follow-up on MRI to check that the tumors are not growing. So let's look at the scenarios of how tumors may affect the imbalance of hormones. We have the hypothalamus, normal, that secretes the hormone releasing hormones that act on the pituitary gland. The pituitary gland secretes pituitary hormones that target organs. And which organs do they target? If we recall the other lectures, it can target the liver, it can target the bones, it can target the gonads, it can target the adrenal glands, it can target the breast, so on, so forth. Then the target organ will produce a second hormone, right, that has some effect, but that feeds back into the hypothalamus and has a negative role. So tells the hypothalamus and the pituitary to stop expressing so much of that hormone. Now, pituitary tumors, they may lead, or tumors in the target organ of abnormal functioning, may lead to primary underactivity. What do we understand by primary underactivity? Is, let's say that the target organ does not work. Okay? One classical example in animals, not in humans. It can happen in humans, right? But let's say testicular cancer, or in animals when there is castration, right? The target organ is taken away because there is castration. The target organ doesn't produce the hormone, steroid sexual hormones. Therefore, this does not happen. There is no inhibition in the hypothalamus and the pituitary. So what happens is that there is oversecretion of the hypothalamus, right, of gonadotrophin releasing hormone, telling the pituitary to produce more LH and FSH, right? So if we compare the hormonal status at this level between the target organ deletion or the normal, we will see increase of pituitary hormone and also increase of the hypothalamic stimulated hormone, because the negative feedback loop does not work. So what do we know as secondary undersecretion is when the pituitary gland does not work. And this can be for multiple reasons. It could be genetic. It could also be uh, because there is a pituitary tumor. So hormone is not produced. The pituitary hormone is underproduced. Also, the target hormone is not produced because it cannot signal to the target organ, but then obviously the negative feedback loop does not work, but the hypothalamus may be strongly producing that hormone releasing hormone because wants the pituitary to secrete more, but obviously the pituitary is not working. So at this level, there may be more secretion. So we have again the normal function, which we know. Now let's say that there is a tumor or abnormality in the target organ. Then what is going to happen is that obviously there is no feedback loop, and then that's the contrary. For example, in a tumor that grows, let's say, in the adrenal gland and produces too much corticotrophin, or a tumor that produces too much sexual hormones, then there's going to be an inhibition, right, of the pituitary and the hypothalamus, and then in this case, they will reduce the hormone stimulation of both the hypothalamus and the pituitary gland. At the same time, the tumor may grow in the pituitary gland, producing growth hormone or ACTH excess that will have an effect on the target organ of the anterior of, for example, the adrenal or the gonads, which then will overreact and produce more of the secondary hormone and affect the hypothalamus to reduce the hormone, secreting hormone. So these are the the several scenarios that can occur when the HP axis is affected by a tumor affecting either the pituitary or either the target organ, and depending whether this is secreting or non-secreting. So, what happens in pituitary tumors? And what we can see here, right, in the screen, is the pituitary gland with a big tumor, which is detected by MRI, and it's a pituitary adenoma that hypersecretes ACTH, also known as Cushing's. Hypersecretion of ACTH targets the adrenal gland. We will study this together, me and you guys, next week on Wednesday, Thursday, and Friday. So what happens is that ACTH targets the adrenal gland. The adrenal gland, because there is more ACTH, produces a lot more cortisol and then feeds back negatively into the hypothalamus and the pituitary gland to produce less CRH, remember, corticotrophin releasing hormone, right? Because there is too much of this hormone. So this is an homeostatic way of controlling hormone imbalance. So what are the treatments of pituitary adenomas? Normally surgery, and this surgery can happen in both ways or in several ways. The surgery can remove the tumor of the pituitary gland, and this can be through transsphenoidal, but in some cases, craniotomies. But also, what can happen is that the organ that is affected, like the adrenal gland, can be removed. For example, through adrenalectomy in Nelson syndrome. Also, it can be used radiotherapy after surgery, and this is slow, but it's used in highly growth humans. But also, we have now quite a lot of different drugs that can be used, which work depending on the type of tumor. In the case of ACTH producing tumors, such as Cushing's disease, we may use block of adrenal enzymes. Again, we will cover this in the lecture next week. Or because the tissue, like adrenal glands, overproduces too much cortisol, there is the possibility to destroy the adrenal tissue using adrenalectomy. Or drugs that actually affects the secretion of adrenal hormones, such adrenolytic drugs like mitoten. In the cases of prolactin, what we can use as drugs are dopamine agonists. If I were there, I would ask you why a tumor that overexpresses prolactin needs dopamine agonist. As you know from the other lectures, prolactin is in constant inhibition from dopamine. So dopamine from the hypothalamus inhibits the production of prolactin. So if you use a dopamine agonist, what you will do, right, is to increase the dopamine effect of inhibition of secretion of prolactin in prolactinoma. In the case of acromegaly, we can use growth hormone antagonists such as octreotide. We will cover this at the end of today's lecture. So here we go, guys. This is the first line of surgery for the pituitary tumors. And what you can see here is the transsphenoidal surgery using endoscope. Now, this is what is used now, but before they used to use craniotomy. And even craniotomy, opening of the entire brain, is still used in certain very aggressive tumors. So what you can see here, they put the endoscope through the nose, right? And there is obviously a little bone that needs to be broken, which is called the sphenoid sinus. Remember on the first lecture where the pituitary was? Then you go through the sphenoid bone and reach the pituitary gland. And then the part of the tumor is taken away from the pituitary gland through the nose. This is the less invasive because otherwise there is no possibility to get into the pituitary gland. Also, there is pituitary radiotherapy. So normally there is a combination of first surgery, then the patient goes back home, and depending on whether the tumor regrows or not, then the doctor may decide to do surgery plus radiotherapy of the left tissue. However, the radiotherapy in the pituitary is very tricky because of the area of the brain that it is. It can damage pituitary cells within the rest of the healthy pituitary tissues, can be used in tumors where after the surgery there is still increased, for example, hypersecretion of the hormone, let's say hypercholesterolemia, or for example, persistence of growth of the tumor itself. It has a slow mode of action, so there are several sessions of radiotherapy, but there are comorbidities associated to use radiotherapy. If you think a tumor in a child that is in the age school and is still learning, it can have secondary damage of different consequences. This can lead to, for example, total destruction of the pituitary tissue, such as endocrine failure. In some instances, radiotherapy after surgery can lead to second malignancy, right? i.e., the tumor becoming more aggressive. It can produce cerebrovascular accident or breakage of the blood system into the brain, and it's been shown in several studies that it can affect impaired cognition. So, obviously, the operations of these pituitary tumors have secondary effects and associated comorbidities. So, 26% of the patients have overall acute complication. 10% of these patients end up with diabetes insipidus. Remember, guys, diabetes insipidus is nothing to do with the diabetes of the pancreas or insulin and sugar, which you will study in the second part of this module. Diabetes insipidus is where the antidiuretic hormone or arginine vasopressin is affected. So that is by damaging the posterior lobe, the posterior pituitary. If the posterior pituitary is damaged, there is no arginine vasopressin or antidiuretic hormone. Therefore, there is no regulation of osmolality of the blood. And this leads to electrolyte imbalance and can lead to death, right? As we can see here, electrolyte abnormalities in the blood due to diabetes insipidus and abnormal posterior pituitary damage. It can also lead to a neurological deficit, and also it can lead to CSF rhinorrhea. I don't know if you know what this means, right? But basically is leakage of the cerebrospecial fluid, right, into the sinuses. Leakage of this liquid obviously is very damaging if it goes into the sinuses because it's been broken through the operation. So, as you can see from all these clinical aspects, although pituitary tumors are not metastatic, i.e. do not spread, however, they are highly morbidity, and because where they are, they have a very severe implication for these patients. Then there are other complications which are more common with like patients on Cushing's disease. We're going to study the comorbidities in the other lectures. And other comorbidities is, for example, if there is damage of the hypothalamus, as I shown you in the picture, there is obesity, severe obesity, sleep apnea, also feeding behaviors, and also there is lethargic consequences, or day-night sleep disturbances, and a whole lot of other complications. So we're going to start first, again, with the defects of prolactin secretion. This is no need to say that we will study in the other modules the ACTH and the other hormones, but that will be associated to the other axis. But today we will study the prolactin and the growth hormone. So, abnormalities in prolactin secretion, they can be associated to hyperprolactinemia. Hyper means increase in secretion of prolactin, and this can come from different physiological conditions, but also from pituitary tumors overexpressing prolactin, known as prolactinomas. So, hyperprolactinemia means high prolactin in the blood. Prolactinomas are benign tumors, but I hope I'm going to convince you, as all pituitary tumors, they may be benign, but because of the area that they are growing, they are really nasty tumors, and they can lead to mortality and severe comorbidities. They are secreting tumors that overproduce prolactin of the pituitary gland. Prolactin is the only anterior pituitary hormone, as we have studied, that normally is under tonic inhibition from the hypothalamus. And my question to you, although I cannot hear you, is what does inhibit prolactin from the hypothalamus? You should know this by now. But if you don't know it, make a note and you can go back to it. So hyperprolactinemia can be caused by several physiological conditions. For example, because the hypothalamus is inhibiting prolactin, if there is a disconnection between the pituitary gland and the hypothalamus, i.e. by growing non-functioning pituitary tumors, or by accident, or because there is a dysfunction on the blood vessels or other diseases, that will stop the inhibition and prolactin will start being expressed. And also for prolactinomas itself or tumors just expressing prolactin. Hyperprolactinemia as a condition, right? When you're going to be doctors and working in the clinic. We're going to cover etiology and causes, the presentation, investigation, and management of prolactinomas. So here we have the etiology of prolactinoma, and what you see in this graph is the concentration of serum prolactin in nanograms per mil. And you can see here in the red bar the increase on prolactin secretion of macroprolactinoma. You can see a massive increase in here. With a microadenoma, there is an increase. Also, there is an increase with certain pituitary disease, which stop the inhibitory effect of the hypothalamus. And also, when do we have an increase of prolactin? What did we study? Prolactin is important in breastfeeding, production of the milk. So in pregnancy, there is an increase in prolactin. Also under stress, and also, as we will see, on secondary effect of certain drugs, psychoactive, antidepressants, several drugs that we will see. So, increase and presentation of hyperprolactinemia, physiological, pregnancy, lactation. Remember, lactation, suckling of the child, triggers the nervous system, right? To stop the inhibitory factor. I haven't told you just yet which one it is. Physical, increased exercise, or psychological stress. Other hypothalamic pituitary disease, non-functioning adenoma, micro or macroprolactinomas. And drugs, important, that affect the endocrine metabolic causes. For example, drugs that act on the polycystic ovarian syndrome, hypothyroidism, right? Hypothyroidism may increase for the negative feedback loop, increase thyroid releasing hormone. And remember, if we go to the slide of the other presentation of yesterday on the hypothalamic hormones, thyroid releasing hormone activates prolactin, right? So you need to start putting all this into a scheme, right? Because everything is connected. Cushing syndrome, chronic renal failure, and severe liver disease. Several drugs that can increase the prolactin production. There are antidepressants and antipsychotics. Also, drugs used for nausea and vertigo, such as phenothiazines, metoclopramide. You don't need to know the names. You just need to know that some drugs affects the dopamine area and basically it will stop the inhibitory effect. You just need to know that some drugs has as a secondary effect the increase of prolactin, and others such as estrogen, right? So the mechanisms is inhibition of secretion action of dopamine, right? Because dopamine is the inhibitory factor of prolactin. So if we go back to the presentation, right, that we did yesterday, you're gonna see that prolactin is in constant inhibition of by dopamine. So dopamine antagonist, stimulation of the central serotonin pathway, and reuptake inhibitors. How do we classify prolactinomas? Again, they are classified, these tumors, by the size, just like adenomas. So it's the same principle as pituitary adenomas. So they are classified as microadenomas or microprolactinomas when they are smaller than 10 millimeters, and these affect 90% of the all prolactinomas. Macroadenomas or macroprolactinomas when they are 10 millimeters, and these ones can be very nasty because they grow to giant prolactinomas, right? And they are 10% of all prolactinomas. Giant pituitary adenomas when they are more than 40 millimeters. Then it's very rare, but some of the prolactinomas undergo malignancy, i.e. they spread. So this is just a picture of showing prolactin cells, and they are characterized because they are lactotrophs, and the expression, you can see the expression of the lactotrophs, right? And normally they are polygonal cells that wrap cells processes around adjacent cells, which are the gonadotrophs. So you can see this wrapping cell, another wrapping cell, and they are another wrapping cell, and they produce prolactin. So the presentation of prolactinoma is different in women and in men. They will have different effects, right? So in women, they will have oligoamenorrhea. I don't know if you guys know what is amenorrhea. If not, you need to study and look what it is. But amenorrhea is a stopping of the cycle, the periods, the menstrual cycle, right? And there is primary amenorrhea, secondary amenorrhea. Primary amenorrhea is lack or very delay of the first period, which normally occurs in girls at the age of 13 or 14, plus minus variation depending on the population, area, and race, and also different other factors. But primary amenorrhea normally occurs between the age of 13 to 14. In this case, hypersecretion of prolactin produces secondary amenorrhea, which means lack of periods. And if you think that there is lack of periods, then it leads to infertility. Now, increasing prolactin and lack of amenorrhea, it has a very severe effect on osteoporosis. That's why in elderly, when the periods stop, in the menopause, there is increase on osteoporosis after menopause. Also 90% presents with galactorrhea. Do you guys know what is galactorrhea? You can also have a look, but I'm gonna tell you now. Galactorrhea is production of milk by the breast without being pregnant. Obviously, this is quite damaging because in a normal situation, you cannot be producing milk. Also, infertility or subfertility. So, increasing hyperprolactin produces infertility. Also, it leads to hirsutism. Do you guys know what is hirsutism? This is growth of facial hair like men. So women that have increased prolactin may have ectopic hair. You can look this up also. And most importantly, obviously, presence of hyperprolactinemia leads to reduced libido. How about in men? Because men also can have prolactinemia, right? But men, obviously, they don't have periods. But it causes erectile dysfunction. It causes impotence. And the galactorrhea presented in women also can happen in men. And you can see a picture here with gynectomastia. So is increase of the breast. So men can develop breast enlargement with increased prolactin. And this breast can secrete milk. So you can understand it's quite damaging, right? So obviously it's important to detect hyperprolactinemia. As I said, it can produce breast hypertrophy, although this is rare, reduce in facial hair, beard, and importantly, reduce in libido. So very important clinical presentations of hyperprolactinemia. Now, the degree and severity will be depend on the tumor size. Normally, there are micro, but obviously if there is a macro prolactinoma, will be more prolactin. And the presentations, apart from the list that I have shown you here, there are headaches, visual disturbance, and symptoms associated with hypopituitarism. So we're going to study the causes of hyperprolactinemia, such as physiological, pathological, and pharmacological. So the causes of hyperprolactinemia may cause for sleep, physical exertion, food, stress, coitus, pregnancy, and postpartum stage, and nursing. Also stress and pain, right? And this produces an elevation of 2 times the normal levels of prolactin. And this is measured. You don't need to know this exact measure unless you do full endocrinology, but all that you need to know is that there is an increase in circulation blood of prolactin levels. So the pathophysiological causes of prolactinemia are pituitary hypothalamic disorders, prolactinoma, acromegaly, other pituitary tumors, infiltrative disorders, hypothalamic and pituitary stalk disease. Other we will cover in the second part of our lecture, because now it's time to have a break and we will deep down into more hyperprolactinemia tumors, but also in the very interesting disease of growth hormone secretion. So we will start the break as per now. Thank you very much, and I'll see you in 30 minutes.